money na hand, back na ground. Oh. This one na razor blade, Sam baby pancake. Oh. She no go like me to say, she old pass her mama. Tell am just slow, kata kata go boss. And everything go papa. She go felele find her way. Oh. And you not gonna see him again. Oh, Juro, what just happened this land? Oh, my girl, yo, my girl. Oh, muja, oh, yeah, you never read. Oh, my girl. Which one you did, sir? Now small we did do one. Shake 'em, 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 shake 'em. Yesterday, not be free your own today. She go tell you say, not be only you be her lover. Put gear for ground. Now Akpan-Iquot done it. Original and young, get money na hand, back na ground. Oh. This one na razor blade, Sam baby pancake. She no go like make you say, she old pass her mama. Tell am just slow, kata kata go boss. And everything go paka. She go felele find a way. And you not gonna see him again. Oh, Juro, mas já sabe isso é. Oh, my girl, oh, my baby, que baby. Oh, muja, what yeah you never read. Oh, my girl, I am you. Oh, Juro, mas já sabe isso é. Oh, my girl, fair, muja.
standing right there beside a well, and I heard a whisper, what you wish for you can have. Then the vision went away, I thought that I had lost her. The girl I've been waiting for, I can't believe I just saw her. She is the finest thing I ever could imagine. Now I want her next to me, cause I want more. Come to me, my Cinderella, straight to my wishing well, and you're the one I'll always cherish. Come to me, my Cinderella, straight to my wishing well, and you're the one I love forever. She is a gentle flower, she is the sun and rain, and she could be the reason for my joy and my pain. First thing I see each morning, last thing I see at night, and you know if I could have all that, that's all I'd wish for in my life. Why did she have to go? What do I say to find her? This girl is the only one, I just cannot deny her. She's making love to my mind, and I can't forget this feeling. It's her voice that's calling, it's her voice I need. Oh, come to me, my Cinderella, straight to my wishing well, and you're the one I'll always cherish. Come to me, my Cinderella, straight to my wishing well, and you're the one I love forever. Oh, Cinderella. Oh, Cinderella. Oh, Cinderella. You're all that I want. You're all that I need. Come back to me now. Cinderella.
you bless the day. I just drift away. All my worries die. I'm glad that I'm alive. You've set my heart on fire, filled me with love, made me a woman on clouds above. I couldn't get much higher. My spirit takes flight, 'cause I am alive. When you call on me, when I hear you breathe, I get wings to fly. I feel that I'm alive. I am alive. When you reach for me, praises spirits rise. God knows that I'll be the one standing by through good and through trying times. And it's only begun. I can't wait for the rest of my life. When you call on me, when you call on me, when you reach for me, I get wings to fly. I feel that when you bless the day, you bless the day. I just drift away. All my worries die. I know that I'm alive. Yeah. I get wings to fly. God knows that I'm alive. First met, I thought you were my all in all, and all. To me, I felt no sweat. To be your own.
There's been so many things that's held us down, but now it looks like things are finally coming around. I know we've got a long, long way to go, and where we'll end up, I don't know. But we won't let nothing hold us back. We're putting our show together, we're polishing up our act. And if you've ever been held down before, I know you refuse to be held down anymore. Well, don't you let nothing stand in your way. I want y'all to listen to every word I say, ain't no stopping us now. We're on
trying to make it, they only push you aside. They really don't have nowhere to go. Ask them where they're going, they don't know. But we won't let nothing hold us back. We're gonna put our show together, gonna polish up our act well. And if you've ever been held down before, I know you refuse to be held down anymore. Well, don't you let nothing stand in your way. I want y'all to listen to every word I say, every word I say. No, no, no. We're moving, we're grooving. We're moving, yeah, yeah. We're grooving. Move it, move it, move it, move it. Ain't no stopping us now. We're on the move. I know we got the groove. Ain't no stopping us now. We're on the move. We got the groove. Ain't no stopping us now. Oh no, no. I'm on the move. I really, really got the groove. And I know we've got the groove. Makes you wanna really move. No need in trying, no, 'cause I ain't buying. No, no, don't try to stop us. No, no, no.
What do I do if I wanna get through to you? No matter how I try, you always keep me waiting. What do I do if I wanna get through to you? No matter how I try, you always keep me waiting. Remember me, I'm the one you danced with. Remember how we danced so tight I could not let you go. I know it's been a long time, but I'm calling 'cause I've got to be with you. Don't you keep me waiting? Don't you let me know? I've got to be with you. Don't you let me know? I never told you that I love you, 'cause I could never take for granted you'd feel the same. Now I can't take the waiting any longer. I just got to let you know. Don't you keep me waiting? Don't you yes, I've got to let you know. Don't you let me know? So tell me, what do I do if I wanna get through to you? No matter how I try, you always keep me waiting. What do I do if I wanna get through to you? No matter how I try, you always keep me waiting. How did you come to your conclusion? But now you're gonna take a little longer to reply. Even though you know just what you're saying, I guess that's just the way girls play. Yeah, that's just the way you play. So tell me, what do I do if I wanna get through to you? No matter how I try, you always keep me waiting. What do I do if I wanna get through to you? No matter how I try, you always keep me waiting. I would really like to believe that.
one day out of life. It would be so nice. Everybody spread the word. We're gonna have a celebration all across the world. In every nation, it's time for the good times. Forget about the bad times. Oh yeah, one day to come together to release the pressure. We need a holiday. If we took a holiday, some time to celebrate. Come on, let's celebrate. Just one day out of life. Holiday. It would be so nice if we took a holiday. Oh yeah, take some time to celebrate. Come on, let's celebrate. Just one day out of life. Just one day out of life. It would be so nice. We can turn this world around and bring back all of those happy days. Put your troubles down. It's time to celebrate. Let love shine, and we will find a way to come together and make things better. We need a holiday. We took a holiday. Some time to celebrate. Come on, let's celebrate. One Everybody sing silly things without knowing that life brings a change. And they've been checking all the signs. My friends say I'm lovesick 'cause all I keep thinking about is her in my arms. And I won't be the same until she is mine. And my friends keep telling me to cool it now. Watch out, you're gonna lose control. Cool it now. Got to slow it down. You're gonna fall in love. Every day I walk her home from school, and she tells me how she really feels. And there's no doubt in my mind that this girl is one of a kind. Lord. 'Cause all I keep thinking about is her in my arms. And I won't feel the same until she is mine. And my friends keep telling me to cool it now. Got to cool it now. Watch out, you're gonna lose control. Cool it now. Better slow it down. You're gonna fall in love. Cool it now. Got to cool it now. Watch out, you're gonna lose control. Cool it now. Got to slow it down. You're gonna fall in love. All I keep thinking about is her in my arms. And I'll never be the same until you are mine. And my friends keep telling me
We got a girl who takes her time. You must hold the pace, you can't mess with her mind. She feels the same, she'll let you know. Just prepare yourself and be ready to go. And I hope this message stays in your mind, 'cause you almost lost a girl who was right on time. Here's one more thing that you got to know. Just cool it down, stay in control.
you got to cool it now. Watch out, you're gonna lose control. Cool it now. You better slow it down. 'Cause you're gonna fall in love.
watching you for so many days. Now I'm feeling brave enough, I wanna ask you, can I take you out? Hey, what do you say? I'll be throwing pebbles up at your window, so make sure that you're ready when I call.
Dancing tight,
I ain't gonna let you go.
gonna squeeze you all night.
Dancing tight, I ain't gonna let you go.
Gonna squeeze you all night.
Hey girl, what do you say? You say you've never been dancing. Well, just you watch me, girl. I better know what to do. It's easy when you feel the beat and the rhythm, 'cause that's the thing that makes your body move. Oh, we'll be gently swaying through the evening to the early hours of the morning.
Dancing tight,
Hello. I think we should reconvene. I know it's going to be very difficult after the amala and the rice and everything, but we have to do what we need to do. So we're going to be moving ahead very fast. Can we please sit down, please? Just some observation and some housekeeping. The session is not likely to last more than 1 more hour or so. So let's just concentrate, for the next 1 hour. You're allowed to doze a little bit if you want to doze, but let's just keep quiet and respect the speakers. I'm calling the next speaker. Who's going to talk to us? Professor Shade Ogushola is the newly minted Vice Chancellor of the University of Lagos. She is a world-renowned specialist in various fields of infectious disease. Let me tell you a story. I've had this event, this is my third one. The first two, I brought speakers from America, 2 different times, okay? What was very interesting was that the feedback I got was that the best speaker out of all the speakers I brought, even with the American speakers, was Professor Shade Ogushola. Please give her a round of applause for that. You see, they say charity, I always say that, charity begins at home. You need to honor your own. So I said this year, I'm not bringing any Oyibo. We have our own Oyibo amongst us who's going to lead us, okay? So, like I said, when God wants to lift you, he lifts you. Look at the elevation you got shortly before this event. Do you think that's just coincidental? No. It's because God sees the vision in what I'm doing and he wants to promote it. And he wants to know that, he's in support of what I'm doing, okay? So, Professor Shade Ogushola is going to be talking to us about monkeypox very briefly. Please, I'm asking that we talk less. The students, if you talk, I will send you out of this place. And I want them to, those of them that say they want to do infectious disease, they should not do it. I want them. But I'm just joking, okay? They should do infectious disease, okay? It's a good special, okay? Professor Ogushola, please welcome to the stage.
Thank you very much. I said pressure. After that kind of introduction, I have to try and not bore you after the beautiful lunch. I'm going to talk to you about monkeypox, and it's not going to be highfalutin academia, because I know that we have multiple specialties here, from the lawyers, the entrepreneurs, to the academics. So what's going on with monkeypox? Next slide, please. So on the 23rd of July, 2022, the WHO Director General declares monkeypox a public health emergency of international concern, which means that the whole instrument of the international health regulations will come into play to try and contain this organism. So let's see what happened. On the 13th of May 2022, the United Kingdom notified the WHO of 3 cases of monkeypox, all belonging to the same family. 2 were confirmed and 1 was probable. Confirmed means that the lab had confirmed them. And the cases began, the first case was May 5, presented with a rash. On May 6, he was admitted. By May 9, he was referred to a specialist infectious disease hospital. And by May 12, he was confirmed to be monkeypox. Another case was April 30, presented with a rash and was confirmed by May 13. By May 15, 4 more cases presented at the sexual, we will call it the STI clinic, and they were confirmed as monkeypox. All 7 cases were confirmed to have what we call the West African clade of the monkeypox virus, meaning it came from West Africa. So globally now, we have monkeypox all over the world, which was not what we had before. Before, it was more or less restricted to West Africa and the Central Africa. So we now have 73,782 confirmed cases of monkeypox. Most of these, 72,922, are in countries that never used to report monkeypox at all. Only 860 are from usual places in West Africa and Central Africa. So we have cases in 109 countries. 102 of those are in America, in Asia, in South America, in Europe, everywhere, Australia. And only 7 are in only 7 countries in endemic areas. So clearly it's not our problem. So when you look at the top 12 countries with monkeypox, United States of America, 27,558 cases. And if you go down to Chile, 1,078. Please go back, please don't change it. Yeah. And if you look at the deaths, very few deaths. So one thing that comes clearly across is it's not a very lethal disease. Then if you look at the endemic countries where we normally have monkeypox, the DRC, 200 cases, Ghana, 104. Now, Ghana is not a usual place. The only reason Ghana's name is there was that it was where cases were exported to the to USA in 2003. Some animals from Ghana was transported to US, and it caused an epidemic amongst in the US. So that's the only reason Ghana is. It's not traditionally an endemic country, but it now has cases. Nigeria, 92, and Cameroon, Central African Republic, Republic of Congo, and Liberia. And you'll see that we don't have too many cases, despite this huge epidemic. It's not an African thing. Next slide. So what is monkeypox? It's a self-limiting disease, meaning you don't need to treat it. For most people, it will go by itself, caused by monkeypox virus. And it's characterized by fever and rashes that vary in number from a few rashes to thousands of rashes. It typically affects the face and the mucous membranes, and it was first discovered in 1958 in Copenhagen when there was an outbreak amongst research monkeys. Human monkeypox was discovered 12 years after that in 1970 in a 9-year-old child in the Democratic Republic of Congo. Monkeypox is the most important, what we call an orthopox virus since smallpox. It's the same family as smallpox, and that's probably why there's quite a bit of concern. Is it changing? What's happening? Next slide. So this is what if you cut the monkeypox in 2, this is what it looks like. So it belongs to what we call the genus orthopox and the family pox viruses. It's brick-shaped, and the pox viruses are big. So they measure about 200 to 250 nanometers. It's double-stranded, and the most pathogenic of them is smallpox, with a 30% case fatality rate. In other words, if 100 people get smallpox, 30 will die. It's a zoonosis, meaning that it's transferred from animals. We still do not know in which animal it resides in the wild, but it looks as though it's in the rodent family. It's only been isolated in wild animals, once from squirrels and once from a sooty mangabe monkey, just twice. Next slide. And these are these animals. Humans appear to be incidental hosts. Sorry, I've repeated that. Many animals are susceptible. Squirrels, rats, dormice, but you'll see they're all in that rodenty looking family. Next slide. We have two major strains of these monkey viruses. We call them the clades, the West Africa clade and the Congo Basin clade. But more recently, a change has been given to these names because the new best practice is not to name viruses around geographical locations to reduce stigmatization. So the Congo Basin clade is now clade 1. It has a case fatality rate of 10%, meaning 10 people die from 100 cases. But in recent times, the case fatality rate has not gone beyond about 5%. The West African clade, which is what we have here, is clade 2. It's much milder disease. Usually case fatality rate is 1 to 3%, but it now has two subclades, what we call 2A and 2B. 2A is what we have been finding in these endemic countries, and 2B is what is causing this outbreak in the Western world. One thing about the orthoviruses is that they're relatively resistant to humidity, to drying. They are relatively resistant to high temperature. They are relatively resistant to high pH, and so can persist in the environment for long periods. So they easily contaminate the environment and stay there for days. Next slide. So, majority of our reported cases have been in rural rainforest regions. So it seems to like the humidity. And the first reported case was in the US, outside Africa, in 2003, and it was a large outbreak of 47 cases. Next slide. So I did this little timeline to show what's been going on, and you will see that most of these have been in Africa, except for USA that's there in 2003. Until the 2022 outbreak, you would not find any other country except countries within Africa. However, next slide. In 2010, a paper came out that sort of portends for what is happening now. That paper mentioned that there was a major increase in human monkeypox incidents in the Democratic Republic of Congo. Now, Democratic Republic of Congo is where we've seen most of the cases. And so, as far back as 10 years ago or 12 years ago, there had been an increase. And one thing we do know is, for example, even Ebola, before you have an Ebola outbreak in human beings, there'll be an increase in the animal population. So really this outbreak of monkeypox was already boiling, had already started. So there was a study that was done by Rimoin et al. Then, and they looked at active data from surveillance data between 1981 to 1986 and compared it between 2005 and 2007. They identified 760 laboratory-confirmed monkeypox cases. There was an average annual cumulative incidence of 5.53 per 10,000 individuals. And then they compared these surveillance data. And what it showed was that between 1981 and 1986, the incidence was 0.72 per 10,000 population. And then between 2006 to 2007 was 14.42 by 10,000 population, which suggested a 20-fold increase. Now, you could also mention, oh, that maybe the population increased, but they found that there was no change in the polio incidence and other diseases that were being evaluated. This was in the DRC. So there was this dramatic rise, and there are reasons for that. Part of that is because this was 30 years after we stopped smallpox vaccination. Next slide. So when they looked at it, there were certain factors that appeared to be associated with this increased risk of infection. Living in forested areas, meaning you were more in contact with animals. The male gender, many of them were hunters and worked outside the home. Age less than 15, meaning that they were not around and did not get the smallpox vaccine. And then anyone without a prior smallpox vaccine. So what it seemed to suggest, or not even suggest, what they also did was to look at the number of vaccinated inhabitants in the DRC. And they found that in the first, between 81 and 86, 84.7% of people then were vaccinated. By 2006, only 24.5% had had smallpox vaccine. So clearly, there was the waning immunity. And then they found that when you are vaccinated, there was a 5.2-fold reduction in the risk of getting monkeypox. So clearly this distance from when we were vaccinated for smallpox is a major part of it. Next slide, please. So in Africa, because we've been talking about this evolution and this outbreak, what we also found, which the WHO Afro found, was that between 2008 to 2018, there were more cases of monkeypox than in the preceding 40 years before 2008. So certainly the cases had been increasing before this outbreak. Since 2016, we had cases in these countries that I've put here, Central African Republic and so on. And then in Cameroon, there was an outbreak in captive chimpanzees in 2016. Then in 2017, Nigeria experienced the biggest documented outbreak of human monkeypox in West Africa. But we didn't hear noise in the international community. And at that time, after that, we kept exporting monkeypox. People who came here caught it, so we exported some to Israel, UK, Singapore, and USA. However, this present outbreak, it's been difficult to link it to Africa. But the monkeypox has already gone. It knows no boundaries. Next slide. So when we look at monkeypox in Africa, before 1998, these were the countries that were reporting monkeypox. Before 1990, sorry. Nigeria, Sierra Leone, you see most of them were in West Africa and Central Africa. By 1990 to 1999, Cameroon and the Democratic, we didn't have any reports from West Africa. However, I'll mention something about Cameroon. Funnily enough, these two clades, the West Africa clade and the Congo Basin clade, 1 and 2, usually somehow stay in their regions. But it is in Cameroon that you find both. You'll find both 1 and 2. Only in Cameroon. And then by between 1999 and 2000, you have Central African Republic. Again, you'll see most of the cases were there. And then by 2017, you have the spread of cases again in West Africa. Most of the cases have been in Central Africa, the Central African Basin. Next slide. So let's come home. This year, between January 2022 and September 2022, which is the latest data that we have a total confirmed cases, 544. Suspect cases are, however, 1,327. And for those who are not medical, suspect means they do look like monkeypox, but we have not confirmed them from the laboratory. And the total deaths, 15. And most of these deaths were in immunocompromised people. Pardon me, September 2017 to September 4th, 2020. Sorry, this is from 5 years ago, from the epidemic. But this year, in 9 months, we've had 318 cases. Total suspect cases, 815. Total deaths, 7. Now, these 7 are captured also, all this figure is captured in the first data. And if you, next slide. Now, this is just to show you all the states that have monkeypox. Next slide. If you look at this slide that sort of breaks down the slides, you will find that between 2017 to 2022, Lagos had 93 cases, but 63 of those cases were this year. What I've done is show you those ones with red. If you look at those figures, you'll find that most of their figures occurred this year. So the top four cases, but Lagos has always had cases, but there have been few cases. But in 2022, 63 of all its total cases occurred. Rivers has always had, Ondo, for example, had no cases before 2022 and had 24. So we have about 15 states that never had cases, but they now have cases. Most of these cases, the ones at the bottom, this is their first episode of monkeypox. So something is happening. In the northern, the 12 states that didn't have any case at all, never had till 2020, were mostly in the northern regions, except for Osun and Ondo. And then 2 states, Niger and Ogun, had their first case last year, and they had another case this year. Next slide. So something is happening and something is brewing. Now, when we look at the symptoms, because we have to look at what's going on in the world and what's going on here, we have some differences in the kind of symptoms we have. Some things are standard and seem to be across board. In Nigeria, most of the patients have a rash, 100%. Fever, about 88% of patients will have a fever. Headache, they'll have itching. Lymphadenopathy, that's swollen lymph glands, about 65% of them. Chills, sweats, and then myalgia, and some would have a sore throat, and then fatigue. There were oral ulcers, but there are much fewer. Vomiting and nausea, 22%. So when you look at the rash, the most commonly affected places, the face, the legs, the trunks, the arms, the palms, and then you can have some in the genitalia and the soles of the feet. Next slide. This represents the kind of symptoms you get this is from the CDC, the US, which I'm using as a sort of typecast for the clade 2B. Again, rashes are frequent. These are the common ones, fever. But if you move, please, can you press the button? You will find rectal pain, rectal bleeding, tenesmus, pus, blood in the, those are not things we normally see here. And some of the common presenting symptoms in this present outbreak that we don't normally see are the genital and perianal lesions. It's a lot more. And they may occur without even spreading to any other part of the body. Fever, swollen lymph nodes, then pain when swallowing, and oral sores plus fever plus swollen lymph nodes are a lot more common in the 2B clade and probably have to do with the type of demographic of patients that are seen. Next slide. So what's the primary transmission route? Animal to human beings. And that's by either touching, by being bitten by an animal, or scratching, or from preparing bush meat that is infected and you have a scratch, then it can be inoculated. Or direct contact with blood, body fluids, or the skin or mucosal lesions of infected animals, or eating inadequately prepared cooked meat, e.g. suya sometimes when it's not well prepared. So the virus can enter our body through the broken skin, our respiratory tract, and mucous membranes of the eyes, nose, and mouth. Next slide. The secondary transmission route, which is probably what we will encounter more in the urban areas or in hospitals, requires close contact with other patients or with a patient. And it's the most significant risk factor. It can also be spread by what we call large respiratory droplets, which come out of the mouth when we talk, when we sing, when we cough. But usually because they're large, they drop. And they drop on horizontal surfaces as well. And these have implications for prevention. So then it can be by inoculation if you inject in error body fluids, and then direct contact with body fluids, and then indirect contact through objects that have been contaminated by fluids, by patient's fluids or lesions. There has been found that people who live in the same house as a patient who has monkeypox, the attack rate is about 50% to 71%. So close proximity for long periods is one of the major risk factors. Just seeing a monkeypox person and passing by them, touching them briefly is unlikely to cause you an infection unless you have a cut through which. One of the things that we also found was that the West African virus, for some reason over time, has not shown evidence of sustained secondary transmission. It does, but it's not sustained. But this 2B, we're seeing something has changed, and explaining this outbreak better. Next slide. I just wanted to share with you this issue of contamination of the surfaces. A study was done in the UK. It was an observational study, and they were looking at patients that had monkeypox and what was happening to their environment. And they found that there was widespread surface contamination. 56 of the 60 samples taken were positive. They tested in occupied patients' rooms. They tested the PPE of healthcare workers. They tested the room where healthcare workers took off their PPE, and they found that all these places, most of them were contaminated. They also looked at the air samples taken, and they found that 5 out of the 20 air samples that were taken in patient areas were positive for monkeypox. And 3 of those 4 air samples were collected before changing the beds, changing the bed, the linen for patient linen, which also goes back to how we're supposed to handle linen of patients, that you do not agitate them so that you do not aerosolize microorganisms. The good thing, though, was that despite finding the organisms, I don't have the other paper. In general, if you use molecular methods, you will find the organism. But when you're culturing, many of these are they're not viable. In other words, the likelihood that they will translate to an infection is slim, but you will find them. Next slide. So the clinical features. Am I still on time? Okay. The incubation period is usually about 6 to 16 days, but it can range from about 5 to 21 days. The average is about 12 days, that if you come in contact and you're infected, it will take about 12 days for you to manifest. And this infection is divided into two periods. A period where it is more like every other disease. You just have fever, you have headache, and as is typical here, you're likely to say, I have malaria, then you take anti-malarials, it doesn't go, you say it must be typhoid. But one thing that distinguishes it is that people tend to have lymph nodes. I don't know, swollen lymph nodes, which is the main distinguishing feature. Then people have back pain, body pain, everything like malaria. So everything that's fever with back pain, body pain, bitter in your mouth is not malaria, could be monkeypox beginning. And then an intense lack of energy. Next slide. Then you go to the next stage, which is the stage at which you now have the lesions erupting. And they usually start in the same way. They start with a small bump. Initially it's flat. That's over there, the first one, it's just a little elevation, then it becomes bigger, but it doesn't have liquid, then it develops liquid, then the liquid turns to pus, and then after a while it breaks down and then forms a crust. And so it tends to have that evolution every time. And most often affected the face in 95% of cases, the palms of the hands and soles of the feet in 75% of the cases. However, not all cases will develop a rash. Typically affects young people but the age groups being affected is increasing in age. In the last outbreak, I think the average was about 30 years. Again, because they did not take the smallpox vaccine. So people who did, as we say, show me your number, are not likely to come down with severe cases, although some have. Severe cases and death usually occurs in children and younger ages. They appear to be more vulnerable to the disease, and then immune-compromised individuals. The whole thing takes about 3 weeks, sometimes 4 weeks to disappear, then it's gone. Next slide. So why the increase in all these cases? Decreasing immunity to pox viruses in exposed populations. The smallpox vaccine, this seems to be the single most important thing. Smallpox vaccination has cross-protective rate of 85%. However, there might be a waning cross-protective immunity among those vaccinated before 1980. That's one. Two, we're having an increasing proportion of unvaccinated persons in the population. And this increasing proportion of people were born after the smallpox vaccine was stopped. Then there's been an increased opportunity for human-to-human transmission. As I said at the beginning, you might not know you have smallpox. Can I have this? Thank you. The world is a global village, so you have smallpox and then you move on. Can you please make sure the slides? Thank you. And then there's a lot of urban migration from the rural areas to urban areas, and especially in Africa, slums are developing, so there's a lot of overcrowding that's making it possible for these to happen. And we're also having global warming, where with increased exposure to animal reservoirs, we're seeing an expansion of most of our zoonotic diseases. Even Lassa fever is expanding, everyone from their usual traditional areas. And then conflict, displaced communities, and so on. Next slide. Diagnosis. Most times in this part of the world, most people are diagnosing it clinically. If you report it, then polymerase chain reaction, molecular biology is the way it's done, or isolation. Molecular biology is much faster. The isolation requires a lot of capital, it's capital intensive, and also requires a lot of skill. The samples, usually swabs of the lesion, you will grow it, then you have fluid samples from the cross. Test for viral exposure. Serology doesn't work. There's a lot of cross-reaction between the orthopox viruses, so it's not, doing these serological tests is not for diagnosis. What are the diseases that you might make a mistake and think can mix up with monkeypox, smallpox, chickenpox, measles, bacterial skin infections, scabies, syphilis, and then medication-associated allergies. Now, anytime you take samples to assist those in the lab to come to a good conclusion, it's important that you give relevant patient data. And that's really important because oftentimes samples come and there isn't enough information. You need the age of the patient, date of onset of the fever. If there's a rash, you want to know the date of onset of the rash, the date when the specimen was collected, and the stage of the rash. It would also be helpful. Next slide. So is there treatment? Well, we have tecovirimat, which was developed for smallpox. It's been licensed by the European Medicines Agency this year. It's not yet widely available, so technically, for all intents and purposes, there's no treatment per se. Most people will not have access. Vaccine, one was approved for monkeypox in 2019, the MVA-BN, which was based on modified attenuated Yersinia virus, the Ankara strain. It's a 2-dose vaccine, again, not widely available. I know in the US, I don't have enough information, 2 vaccines were approved for this as a protocol. The Jynneos vaccine, which is for prevention of monkeypox and smallpox, and then the Akpan 2000, which was really against smallpox, but is being used also for monkeypox. So, next slide. So how can it be prevented? We're almost done. We need to keep active. We need to keep counting. We need to report. And the reporting is important from facilities. The first line is people are going to come to the hospitals. We need to ensure that the reporting lines are strong and people know how to report. We need to raise awareness of risk factors, that's general population. We need to counter the myths so that people feel free to come. And if possible, when we're treating monkeypox, healthcare workers who have been vaccinated against smallpox should be prioritized over those who have not. Now, for every patient that you meet, because the transmission of smallpox is by direct contact, prolonged contact, then you need to, for every patient, you need to make sure that you have a barrier, your gloves, a gown or an apron. And then because we also know that contact and droplet precautions, you might need to wear masks if you're going to be in close proximity of the patient. Everything will be based on a risk assessment. Next slide. So, Professor Abayomi spoke about Agent X. Certainly, we know that a number of studies have shown that the rate at which new viruses are emerging is accelerating. So there is going to be another organism. I mean, and then even the ones that we have are mutating and becoming more comfortable in human populations. So there was this study that was done in 2008 that looked at where emerging infections were likely to emerge, where infections were likely to emerge from. And they looked, if you look at A, those are zoonoses from wildlife. Monkeypox is from wildlife. You'll see that Africa is certainly there. Nigeria, you can see a little red spot there. When you look at B, which is zoonosis from non-wildlife, like your pets and the cats. Can you see us? We're not there. We keep pets outside. They don't lie on our beds, you know. Then when we talked about drug-resistant pathogens, again, we are there. Nigeria is there faintly, you know, because again, part of it also is that there are drug-resistant organisms, but again, because of our lack of access to some of the more last-line antibiotics and new ones, a lot of it is to the normal common antibiotics. And then vector-borne pathogens, again, Africa is there. So that we will not have another outbreak we're going to have more. More are coming. How they come, what they are like, we don't know. But certainly what it means is that we need to be prepared. Next slide. So let me, in summary, I have 2 slides now, say that monkeypox is not lethal and is self-limited. It requires prolonged close contact for transmission. The protective effect of the smallpox vaccination is no longer protective of an increasing number of people because either it's waning or they were never exposed to the vaccine. And the ongoing outbreak in many non-endemic countries was preceded by a massive increase in monkeypox in Africa. Is the monkeypox changing? Well, we now have a subclad 2A that seems to be a little different from the subclad 2. Subclad 2B, very different from subclad 2A. People with monkeypox will contaminate widely their environment, but oftentimes the virus is not viable and may not cause infection. However, that does not mean it cannot happen because you do not know which will be viable or not. Standard precautions will keep most people protected. Hand hygiene, masks when in close proximity, environmental cleaning, especially of high-touch surfaces and areas around patients. Treatment for now is mainly symptomatic because the drugs are not really available, and the vaccine also, though available, is not available. Finally, I come back to infection prevention and control because it's becoming clear that in Africa in general, we do not have strong health systems. Our infection prevention and control is very poor. But that is like what you call your innate immunity. It has to be strong because you don't know what is coming, so you can't prepare. So we need to strengthen IPC. It's a system strengthening endeavor because we do not know what is coming. So everybody needs to know, everybody needs to develop a habit There must be protocols. The countries need to achieve IPC capacity, both at national and facility levels. We have started, thank God, but we still have a lot of work to do, and a lot depends on individual healthcare workers. So we need to strengthen our healthcare systems, because that will help us with our epidemic response. It's not that every time an epidemic comes, we're training people just to do that epidemic, but that it will be something we do naturally. It will become our habit. And if we can continue to do that, then the numbers of deaths of healthcare workers that die when epidemics come or that they become infected will go down. Thank you very much. Next slide.
Thank you very much, Professor, for a beautiful presentation. Well, I've only seen a case of monkeypox in my practice in America. The demographics in America appears to be different. Usually the homosexuals, that's where we see them, yeah. So, wasn't a very severe infection. He came for a regular visit with me, and he had the lesions, which I sent to the health department. They set up for that. One was confirmed. He wasn't very sick at all. We didn't have to offer any intervention. Okay. And another thing that I want people to know about monkeypox is that it's been found that even in semen you can find monkeypox, and it's recommended that 12 weeks after you had monkeypox, you're advised to use condom. Yeah, so that you don't transmit the infection. Okay. So Professor has done a beautiful job. I'm very grateful for your presence as always. I know I can count on you the next time, all the time, eh? Yeah. She has to leave. She has many commitments, but I'm only going to give 3 people just questions, short, please. We don't want it to be boring, okay? Who's that? Cousin? Cousin? Please give the phone to Cousin Fire. Oh, no, Williams. Yeah, Williams. I'm meeting you here now. Yeah.
Thank you very much, Professor Shade Ogushola, for that brilliant presentation. My name is Fire Williams. I'm a pharmacist and I'm passionate about health promotion. I've done that on radio for about 10 years now. My question is, we are not hearing enough about monkeypox, impending Agent X, and other things, especially at the grassroots. Right now, people are going around with reckless abandon in every market. Nobody's using masks. They even think COVID has gone. And from all I've heard today, you are still telling us that it is around. So my question is, what strategies do you think we can adopt to ensure that everybody, every citizen, especially at the grassroots, they get to hear about these infectious diseases, just as we did for polio, myelitis. I remember I was on one of the expanded program on immunization. We used town criers, we went to religious places and all that, but all that seems to have stopped, and it's very worrisome. So what strategies can we use to restore the communication? Thank you.
Okay, let me first say that you've asked the $1 million question. The reason being that COVID is not going. It's not going away. What is going to happen is that the impact may change as we become more immune. And what you're seeing is fatigue. They've been hearing about how terrible COVID is, but they're not seeing their neighbors die. So it's very hard to convince people. We just have to continue to pass on that message. Let me put it this way. Even healthcare workers have stopped wearing masks. So how do you get the ordinary man on the street to wear the mask? Because the reality is, COVID is going to morph into an endemic disease, and it is already doing that. So we were in an epidemic mode where things were heightened. So what I would usually tell people is, if you're going to be in a crowded place, those are our parties, it might be a good idea if you wore a mask. If you are diabetic, you're a vulnerable person, you should avoid those places because COVID is still around. For most of us, whether we wear the mask, we don't wear the mask, we will catch the COVID, we'll be all right. So people may start to think, well, is another flu? I mean, that's what's happening. So rather than have long stories and long lists of things that are not going to happen, let's tell them where the risks are so that we minimize the, minimize the impact of, because people, they don't see the deaths, they don't see it anymore, and it's been going on for a long time. There's a lot of fatigue. So we just say, if you're having a party, why don't you throw the party in the open space? Let's avoid air condition, people sitting together. If you are vulnerable, avoid certain places, and I think we'll get them to move better. Thank you.
I really allude to that. I just have a very close family member who went to trip, actually in Venice, and went with a group of about 21 people, and well, not wearing masks. 8 of them came back to America with COVID. So whoever thinks that COVID is over, you are fooling yourself. I mean, the professors have spoken about the mutation that's happening, that the vaccinations that are being given very soon, they are not going to be very effective against the strains that are coming up. So we still need to take that precaution, we still need to be careful, and I appreciate your answers very well. Any other question?
Many congratulations on that talk.
Thank you.
There's been some discussion going on here, so it came to me to have to ask you, immune boosting, what's your view on this, our common dongoyaro?
Sorry.
Immune boosting your innate immunity, like you said. So now we take dongoyaro, we take ginger and garlic and things like that. So what's your view on
ginger and all that?
Yeah.
They don't, there is no scientific evidence to support. Most of what you get will be symptomatic relief. For as long as you're not doing anything harmful, I don't say don't do it, but recognize that it's not a treatment. You still need to go and see your doctor. There's no evidence to suggest that it works at all. But if you have a blocked nose and you steam inhale, it may help your nose to open, but it's not an immune boost. There's no evidence to suggest that.
Well, there's another twist to that, okay? If you look at the demographics and epidemic of people who died or who were sick from COVID, usually they are very poor protoplasm. What I mean is this, they're usually the fat people, they're usually the people that have diabetes, that have comorbid conditions, okay? So if you have very good nutrition, if you exercise, if you're fit, if you have diabetes, you control it very well, you are actually helping yourself, in fighting against this infections. Not all those ginger and all those things, we are medical doctors and we base things on science. Yes, and evidence, okay? Yeah. Any other question? Okay, this is the last question, please, because Professor needs to go.
Thank you very much, Professor Shade Ogushola. I knew you would always come back to infection prevention and control because that's what you do. I'm just wondering, like you said in your lecture, monkeypox has been something that's been with us for a very long time, very few deaths. And for some of us in the infectious disease community in Africa here, we're wondering why the clamor now, as per declaring of a fake by the WHO, looking at the impacts both in the morbidity and the mortality as to monkeypox. We believe that we have so many more pressing matters that should be attended to and be given that focus and research. So I don't know what are your thoughts on these. For some of us believe, or I believe, that there's just a lot of unnecessary attention based on the effect and the impact that it has compared to it, and there are so many other problems. Is it just this thing of because it's now affecting some other people beyond the endemic zone? It's not a white man's problem. Is that why there's so much focus on it? Please, I would like your thoughts on that. Thank you.
Thank you very much. Spoken like an African. And I mean that in a best possible way. One thing we are always dealing with in Africa, communicable diseases. So we're used to them. We're coming out of one, as you're coming out of monkeypox, you're jumping into COVID. As you're doing COVID with cholera, with TB, so communicable diseases are things that we sort of handle every day, and we see loads of them. So when you put monkeypox beside MDR, TB, you put it against, things that are killing many people, certainly it pales into insignificance. It doesn't kill people generally. So it does pale for us. And so that's where it's important that we choose what we are interested in dealing with. Every country deals with its own interest. Now, the Western world are not used to these kind of communicable diseases. For them, monkeypox is an exotic disease. And truly, we also have to ask ourselves, what's going on? Even though it's not impacting us, we're suddenly seeing the monkeypox moving out of its normal ecosystem, sort of, and beginning to spread, and it seems to be changing. And you know that it is the same family as smallpox. We ask yourself, is something going on? Could it mutate to a more dangerous or pathogenic organism? We don't know, but those questions need to be asked. However, the noise outside Africa is because they've never seen anything like that before. We have, and they have the machinery to make noise about it.
Whatever concerns us. That's very good. I think that's the last question. Well, I have an award for you. Yes. Yeah, play. No, too. Yeah. Where's it? Listen, yeah. Professor, like I said, over the last 3 years, I knock on her door, and she always doesn't say no to me. She travels all over the place, all over the world, giving lectures all over the place, but she always creates time for me. Some other eminent people, like Professor Shade Ogushola, just being elected Vice Chancellor, will say, no, I don't have time for all that. But she never said that. For that, my God will honor you, my God will bless you, will continue to promote you. This is not the beginning, this is the beginning for you. You're going to do more things, like being a Vice Chancellor of that university. And that university is going to grow under you. They're going to say, under the tenureship of Shade Ogushola, that the University of Lagos became the #1 ranking university in the whole world. Yeah. Well, this is a small plaque from the Global Infectious Disease Initiative based in Columbus, Georgia, for you, for your believing in us and coming out every time to give us these outstanding lectures and just giving us, sharing your knowledge with us. We appreciate you very much. May the good Lord bless you. I'm going to give the other awards because they're for people that went to university, so they can come to the stage too. Let me see. The other one. Hey, wait, so that we can take pictures, okay? Oh, yeah, put in there. Take the two together. Bring the two together. Bring the two together.
For he's a jolly good fellow, for he's a jolly good fellow.
Well, this award,
for he's a jolly good fellow, which nobody can deny, which nobody can deny, which
initiative.
Nobody can deny.
Listen, there's a lot of planning that goes into this. The CME is very important to the physicians that come. Unfortunately, a lot of them don't come, but it's sad. Well, Professor Kumbi Banjo, who was my classmate in medical school, over the last 3 years has made sure that we have the CME certificate from all this body that we need to. This year she's done it again, and I think she needs to be recognized for this work. Kumbi, please come and have this, please. Yeah. She used to be better. Actually, Kumbi is very, very special to me. Can you believe that we were born on the same day? We were born on the same day. I'm older than her, Sha.
Oh, yes. For
Kwele.
he's a jolly good fellow, for he's a jolly good fellow, for he's a jolly good fellow, which nobody can deny, which nobody can deny, which nobody can deny. For he's a jolly good fellow, for he's a jolly good fellow, for he's a jolly good fellow,
Okay.
which nobody can deny.
Old MacDonald had a farm, E-I-E-I-O, and on that farm turned E-I-O.
Hey, don't go here, Joe. Don't go here. Yeah.
For he's a jolly good
Well,
fellow, for he's
I
a jolly good fellow, for he's
recognize,
a jolly good fellow,
the
which nobody can deny, which nobody
planning
can deny, which
of this
nobody
event.
can deny. For he's a jolly
For the last 3 years, I've had the
he's a jolly good fellow,
pleasure of working with Mr.
fellow,
Udo, who has been the organizer for this event. Do you like this event today? If you say yes, we'll get her next year. If not, we'll fire her.
Yes.
Yes or no? Okay, you are hired again. Mr. Udo is being presented with this for a job that's been done over the last 3 years. We appreciate your efforts and thank you very much.
Which nobody can deny. For he's a jolly good fellow, for he's a jolly good fellow, for he's a jolly good fellow, which nobody can deny, which nobody can deny, which nobody can deny. For he's a jolly good fellow, for he's a jolly good fellow, for he's a jolly good fellow, which nobody can deny. Oh, yes! For he's a jolly good fellow, for he's a jolly good fellow, for he's a jolly good fellow, which nobody can deny, which nobody can deny, which nobody can deny. For he's a jolly good fellow, for he's a jolly good fellow, for he's a jolly good fellow, which nobody can deny.
Ladies and gentlemen, we present to you one of the best choirs in the city of Lagos, Nigeria. Come on now. Baby, what? Say what?
Well, we have to move very fast because the day is moving very, very fast, and we need to get to the end. We have the last speaker who graciously accepted to speak in place of Dr. Kemi Olukoya, who was on the program for some emergency. She went abroad, and she's asked Dr. Oluchi Kama Okafo. He's an infectious disease and global health specialist, senior lecturer at the College of Medicine, University of Lagos. She's just going to be talking to us very briefly about the social economic impact of COVID. And that will be the last lecture. After that, I'll tell you what the agenda for the evening is going to be. Thank you.
Ladies and gentlemen, we present to you one of the best choirs in the city of Lagos.
Good evening, everybody. I'll be standing on the existing protocols. It's been a wonderful afternoon, and I hope I can impress you as much as I've been impressed. May I have my slides, please? So I'll be talking about the socio-economic impact of the COVID-19 pandemic in Nigeria. Since the pandemic started, it ended with so many people being in a different place from where they were before it started. People were severely affected. And so we want to take a look at this and look at how, how to put this effect in perspective, and then look at ways to possibly help ourselves plan to do better in the years ahead. Next slide. Next slide. So this is my outline. So we know about Nigeria, Africa's most populous nation, an emerging global power, the largest economy in Africa, and the 31st largest economy in the world. So we are huge, we're big, we're a force to reckon with. But before the pandemic even, we had some challenges, especially with our socioeconomic indices. When you look at things like food insecurity and hunger, the number of people living in poverty, our indices are so high, and we have the causes of death to be around infectious diseases, things that the rest of the world may have overcome. So we had some challenges even before COVID started. Next slide. So from the time it started, we have so far recorded over 265,000 cases and over 3,000 deaths, worse in Lagos, the FCT, and Rivers states. So from this graph, we can see the trend, how we gradually went from nothing to coming to where we are now, over 200,000 cases. Next slide. And even more currently, the trend as at today, yesterday, shows that we're still pretty much within COVID. It hasn't, many people think it has gone, but it's still here. Looking at the most affected parts of Nigeria, Lagos, the FCT, and Rivers, you can see that the infection is still going on. People are still being affected by the pandemic. Next slide. And when it came to Nigeria, we had an excellent response, especially in Lagos State. We applied measures like lockdowns, restrictions, border restrictions, contact tracing, the measures that have been outlined already. And then those measures that were closer to the individual, things like social distancing, public enlightenment, people applying measures. And until we got down to vaccination with its problems, people have, largely over time begun to reject the vaccine. So these are the problems that we experienced with COVID-19 in Nigeria. Next slide. And so there are some factors that are unique in Nigeria that has sort of determined our experience of COVID-19. Things like our large population, which is in itself not a problem, but the fact that these large populations live within densely populated suburbs. Then a lot of migration. People go in and out of Nigeria pretty rapidly. Links to regions most affected by the pandemic. Then we have our health challenges, healthcare challenges, overburdened health system, where we have our problem in our infrastructure, healthcare financing, and then brain drain. A lot of our health workers are leaving the country. Then we have weak public health systems relating to surveillance, reporting, universal health coverage. Not everyone has access to good health care. And then primary health care, which is the one that is closest to the individuals, is weak in Nigeria. We already, before COVID, had social, economic, geographical boundaries that put us in a place where healthcare is inaccessible to everyone. And then we had pandemic preparedness to an extent, which generally could have been said that we were unprepared. Then the infrastructure that should protect us is burdened by things like corruption, insecurity, then underdeveloped social systems. We don't have a social structure to help the vulnerable ones. Then we have high poverty levels, and our economy generally struggles. Next one. But looking at the impact of COVID-19, it can be said to have been looked at, it had two effects, two sides of a coin. We can look at the upside and the downside. Next slide. So looking at the upside, the pandemic did something for us. It helped to put our health in focus. It helped to bring out our problems, helped to allow us to identify our challenges and to begin to find ways to address them. An example is the strengthening that went with molecular laboratory testing, things like more advanced technology was allowed to come into healthcare. So that's the upside. Again, we had more health workers coming forward, people are getting trained, putting together the infrastructure to fund research, funding. A lot of healthcare received a lot of funding in that year. Then our problems were brought forward and solutions came through. Next slide. And looking at the downside, all the sectors of our economy were affected by the pandemic, virtually all the sectors. But very critically, the health sector. Things like access to healthcare. It wasn't apparent before COVID-19, the pandemic, that healthcare was inaccessible in Nigeria. People who needed care didn't get care. Not because there weren't any hospitals, but because we didn't have the infrastructure to be able to cope with something like a pandemic or an infectious disease of that magnitude. Then education. We didn't have the infrastructure to address education in a situation like that. Even our very weak educational system bore most of the burden at that time. And then labor and industry. People had income reduction, people had to work without pay, poverty increased, and there was food insecurity. Then other services like tourism and other non-essential services, people that just ordinarily their work are important but are not in the front burner, they were the first to be affected. Then in the sector of oil and gas, which is our most important sector because that's where we get most of our revenue from, there was a lot of shortage. Agriculture, finance, aviation, the transport system, every system was affected. Then we even saw the effect when it came to things that were related to the individual. And these are called gendered effects. Things like intimate partner violence, violence, largely. Then mental health. A lot of people went through a lot of mental health issues. We saw suicides go on the increase. We saw families break down. Next slide. So just to put into perspective Nigeria's socioeconomic picture, Nigeria is a country with obvious potential, but we are yet to use our potentials together, apply them together, and allow our economy to diversify. And then the true picture of our economies is in where you see that we have resource windfalls. We have our oil. But we have limited technical capability. We have our oil, but do we know what to do with it? We have weak checks and balances, corruption everywhere. Then things like a system where the elites capture the wealth. So you have the very rich and the very poor, and then weak social systems. And so the consequence, immediately COVID-19 arrived, was to expose our fragile socio-economic environments. Next slide. So let's look at the effect on different aspects of our country, particularly our economy. It reduced the demand for crude oil globally, and that significantly affected our economic growth. Oil production also reduced drastically. Even workers had to be retrenched, and this led to a depreciation of our currency. And it had its effect in different areas, in the health sector, in education. Then looking at households, many households during the pandemic were crippled. Household income dropped significantly in most homes, and expenditure went up because many people had to pay for healthcare that they wouldn't ordinarily have to pay for if the pandemic had not occurred. And then in Nigeria, we have a health system where many people pay out of pocket for healthcare. We don't have insurance, or we don't have a system that bears the cost. So many people have to pay out of pocket. And when the household income is poor, that's the first that is affected. Then food expenses. Prices of major food items, and virtually every item went up by over 85%. Then transportation costs, internet connectivity in this age where we really do need the internet. So the costs were enormous. Then looking at labor and employment, about 42% of respondents in a study it was found that about 42% of them had labor challenges. Then in the urban areas, there were a lot of job losses compared to rural areas. Then income losses occurred in up to 80% of Nigerian households. And then 58% of households reported a decrease in income that is specifically related to the pandemic. We had 21% of closure of businesses in households, and the poorest households were the most affected. So this pandemic affected the poorer people the more. And looking at how the working situation of Nigerians, it was found that more people stopped working related to COVID-19 compared to those who stopped working that's unrelated to COVID-19. And then looking at the proportions of people that are currently working, it didn't seem to rise in the period or during the pandemic. Next slide. Now, on the health sector, the sector that was bearing the burden of the pandemic, there was reduced access to health. Costs were skyrocketing. Then people had this fear of being diagnosed of COVID-19. And that fear of going to the hospital and being diagnosed was a major reason why people avoided the health system. Then there was a shift to interventions like telemedicine, remote medical support, and these are expensive to engage. Then health financing reduced because a lot of funding was diverted to the COVID response. And also, a lot of our health systems depend on donors, and most of their funding went straight into the COVID response. Then on education, schools were closed, schooling was interrupted. Then it was also found that poorer children were disproportionately affected because the richer families could afford internet learning, they could afford homeschooling, and they could afford platforms that allowed people to have courses online. And this has affected the opportunities for learning. Looking at, in this time, in the period of the pandemic, you find that many children currently have learning gaps. The last exams will give you evidence. Results are dropping. So the educational system is going to have to work doubly hard to get its children back to where they ought to be. And then the effect on children's caregivers. Caregivers were becoming overwhelmed with having to play the role of parent and teacher at the same time. The effect on education can be shown in this way, showing that if you look at the trend from the poorest to the richest, it is the people that did not engage in learning was worse among the poorest, even though it didn't seem to be so different. So we can comfortably say that the educational challenge ran across board. So let's do it like a case study of people that are affected by the pandemic. Now, in case one, real people affected by COVID-19. We're looking at this woman, Mrs. O. She lives in an urban slum. She's married. She has 12 children, yet relatively young. Husband is not very socially strong, and she suffers intimate partner violence. In her own words, she says, COVID really affected us. I just thank God, because not every time that we eat. She was having feeding challenges. And then she was saying here that it depends on the food they eat, they see. So they ate what they saw. And then because of the severe challenge on their family finances, they were looking for funding. And she said, nobody to feed us. There was nobody to feed us. I do not go to the markets. I do not get to sell my wares. So her business was affected, and it affected her family. Now, case two, a little bit of a difference. This is a 69-year-old diabetic hypertensive, retired civil servant. He's widowed as well. And he has 2 children in university, so he has a double challenge. So in his own words, says, during the lockdown period, I was sick. I felt like malaria. It felt like malaria, but I was afraid it was COVID. I did not go to the hospital, even for regular appointments. And it's, to him, that was the wisest thing he could have done to avoid the health facility. Now, looking at case three, a young 23-year-old female, an undergraduate who had in the past had educational challenges. And at the end of the pandemic, she was beginning to question her interest in education. She had lost that interest, and that's one more manpower resource lost for the country. Next slide. So the next pandemic is inevitable. We've heard that all day. It's coming. When is it going to be? Who has an answer to that? When is it going to be? But how can we prepare? When you know you have an impending challenge, the best thing to do is to prepare. How can we prepare? Epidemic preparedness planning. It should be given top priority. We don't have to wait for the next challenge. We should begin now. Each person begin now to prepare for the next pandemic. And there's a way to prepare, a way to go around this, the 5 M's. We're looking at putting the system in place, the machinery in place to make it possible to be ready. Putting the manpower in place. Now, all our doctors are leaving the country. We're experiencing brain drain. Can we train more doctors? Can we have a more focused training towards the doctors that are still here? Then can we begin to think about putting more funding into healthcare and then making the materials that are required available? Can we maybe deal with the shortages? And this is all, so the main thing in epidemic preparedness right now is management. Then we have to build on the gains of the past pandemics, the Ebola and now COVID-19, build on them, be innovative, build teams, sustainable teams, and then a multi-sector approach when it comes to dealing with the pandemic. No sector should be left out. And then for anything to be possible in pandemic preparedness, strengthening the health system. It's about that time we've begun to strengthen our health system. And then things like healthcare reporting, the IGSR mechanism, it's time to begin to strengthen that as well. So in conclusion, it's a dual crisis affecting both health and economic status. It left people poorer. Typically, infectious diseases leave people poorer. And that's probably one of the challenges that we have in this part of the world. Diseases that are common here, like tuberculosis, malaria, they all lead people to lose work time, to lose money, and to lose their livelihood, lose their ability to work. And so infectious diseases are essentially impoverishing diseases. They make you poorer. And so it's about time we began to look at health in that way, because truly health is wealth. So it exposed a huge gap in our system, in our health system, and the lack of adequate pandemic preparedness. Even after we've been through COVID-19, we're here, and going forward, that socio-economic challenge is going to linger. People are still suffering. A lot of families are still in the poverty that COVID-19 left them. And so we need to place efforts on those things. And we need to prioritize on the lessons that we have learned about COVID-19 going forward to cause there to be a kind of cushioning effect should we have another pandemic. So we need all hands on deck to apply all the measures that have been learned so far. And these are my references. Thank you.
Doctor, thank you very much. I know your lecture came after everybody was tired, but at least you gave us some very exciting things about the social issues that faced us after the COVID pandemic. We appreciate it. Does anybody have any lecture for any questions? Any questions? No questions. Okay. They say there's no questions for you. Okay. Thank you very much. I appreciate you. God bless. Maybe next year we'll give you an award. Okay. Okay. Well, we're coming to the end of this gathering. I know that most people have gone and everybody is tired. Okay. So I'm not going to bore you. I just want to thank everybody that contributed to the success of this by your time, by your prayers, by your donation, and by even coming. I really appreciate each and every one of you. If there's any one of you that has any question, 2 or 3, because I don't talk too much at these conferences. I like to convene, I like to arrange, okay? But if you have any questions that have been bothering you in infectious disease, maybe the students or the residents, you can ask me now. Just 3 questions. Give that microphone to me. So we can dance. Wow.
Yeah, thank you. Good afternoon. My name is Akpan-Iquot. The question I have regarding infectious diseases generally as a whole. So, when the COVID-19 came, everybody was asked to wear masks, use personal protective equipment in the hospitals, and then for going out, gatherings, people were asked to take precautions generally. But I believe that many of those precautions were panic precautions. So most of them don't have long-term, they cannot be held long-term. So what I want to understand is, you know, COVID-19 and other infectious diseases that are coming up, because has changed the world largely, right? Because the world has become a global village. So there's a lot of migration, people are mixing. So diseases that didn't used to spread so much are now beginning to spread. There are new infections every day. So what I want to understand is, are there other protocols that we can now instill, newer protocols that can be used long term, that even the layman can incorporate in their daily life? And how can we spread these things to the communities so that we can be able to cushion infectious diseases in the communities before they become really overwhelming? Thank you.
Well, thank you very much. You know, that's a very good question. In infectious disease, there is what we call standard precautions. It's standard, you know. So, I mean, as a patient, you know, as a doctor in the hospital, you want to see a patient, you're supposed to wear your mask. You know, I mean, before COVID, we didn't used to wear masks, but now, I mean, in America, we're still wearing a mask. But the most important thing is, you know, being very vigilant, you know, as a person, and making sure that, you know, you yourself, as a possible patient, looking out, you know, for people that could be infected, that are sick, that you can, I mean, encourage to, you know, go and seek care, or you yourself, you run away from them. So most importantly, you know, having, like I said, I always go back to the fact that, you know, your health is very important too. You know, taking very good care of your health. You know, you can't be having diabetes and your sugar is not very controlled and be praying that, you know, some disease will not, you know, jump on you, or you're on some medication that is suppressing your immune system. So what I'm saying is that, you know, education is the key. You know, take care of yourself. You know, I mean, if you need to wear mask or gloves or mask, like the monkeypox that we're talking about, do it. So that's the simple question, okay, and simple answer to your concern, okay? Any other question? Nobody question? Okay, everybody has a certificate of attendance, and there are 3, one person. Yeah? One other person. There's one of our sponsors here. Oh, there's somebody that wants to ask a question. Get up and ask the question so we can quickly go.
Okay. My name is Ife. I'm a student of public health, master's, and I have a background education in microbiology. For my thesis, I worked on mycology, and I was able to inhibit fungal growth using, bitter leaf. And there was a question that was asked earlier, talking about the importance of ginger and other food products in the successful inhibition of antibiotics, let's just put it that way. And so my question now is, if for public health research, most of them are usually evidence-based. For us to be able to formulate policies in public health, they have to be evidence-based. My question now is, how do we, because you telling me today that there is no scientific backing for ginger being an antibiotic or something like that. I have been able to do this. As a matter of fact, my supervisor is working on publishing this. So how do we put this in writing that, as a matter of fact, we have fungal growth inhibitory properties in some of our plants today?
Well, that is a very big opportunity for someone like you, to pursue, okay? Don't forget, most of these medications that we use, they are plant-based, and they are extracts that, go through the lab, to be processed and all the rest. So if that can be done, there's no reason why, what you're saying, can't be practiced. Nobody is saying that, you should throw it to the garbage, but it has to be, like you said, it has to be scientifically based, it has to go through rigors. In America, no matter what you want to do, you have to go through the FDA, to approve whatever medication, and they're going to ask you that, where do you get the chemical from, the composition, and all the rest. So young scientists like you that are coming up, if you can get people to let you know what the components of these things you are talking about, it can be analyzed, and you can write papers on it, to promote your thoughts, okay? Yes. Okay, only one person, one of our sponsors just want to say one or two words. Where is it? Biologics, hurry up. Where is it? Thank you.
Good afternoon, everyone. I'm Noah from Biologics Support Service, and on behalf of the CEO, Dr. Vuki Toye, I'm happy to say that we are very glad to be a part of what Dr. Folarin is doing, to be a part of the Global Infectious Disease Initiative. Biologics Support Service is an indigenous biotechnology firm. We have the vision to provide a space for the expression of biotechnology, of molecular genetics in Nigeria and in Africa. So we are into research, genetic research, molecular research. We are into the development of testing of diagnostic tools that are specific for the Nigerian population. We offer testing services as well. We offer testings for infectious diseases, COVID-19 that we've talked about. We offer the testing. We offer testing services for hepatitis B virus as well, and we offer testings for non-infectious diseases as well. We are into the development of molecular genetic testings for cancers. We know cancers are non-infectious diseases, and they are a global threat to humans. So we have offered testing services for breast cancers, and we are still trying to develop a number of other cancer testings. Also, we are into training the next generation of scientists, of molecular scientists now. We heard that there's a huge gap to be filled for bioinformaticians in Nigeria, in the Nigerian science space, and we are into this field. We are actively training the next generation of scientists. In fact, we have trainings for young children from the ages of 12 upward. We have different categories of training that will benefit us. And we are currently having a training that is ongoing for scientists. This training is sponsored by the Bank of Industry, and we have a stand at the back there. You can just walk up to us. We have a lot to offer Nigeria in terms of biotechnology, genetics, and research. So thank you very much. We are glad to be here. Thank you, sir.
Thank you very much for. Okay. There's another person here. Sparklight. Please. Without people like this, we are not going to be able to do this kind of thing. So we need to honor them. Thank you.
Good afternoon, everyone. My name is Olakunle Smith, and I'm from Sparklight Property Development. Sparklight Property Development is a real estate company, and one of the things we do is that we have access to mortgage for the properties that we have. I'm going to be sharing the locations of where we have our properties. We are not a company that come and bluff about the products that we have, and there's nothing to show for it. We have our properties at OPIC. We have our properties at Magboro, which is opposite MFM. We also have our property at Ogombo, Abramade Soya. We have our property also at Grace Court, Ikota. I wish we had a slide. I would have showed you the things that we have. Our properties are already existing. People are living in the estate already. But the beautiful thing about it is that you can obtain this property via mortgage. You don't have to. We love you to buy the property outrightly, but one of the benefits of investing in our company is that you can have access to mortgage at 6% interest rate. A lot of companies out there, I'm not trying to compare our company to others, but the mortgage that is mostly available comes in 2 digits, above 6, usually 2 digits, like 12, 10. But ours, we are offering 6% mortgage interest. We do NHF, Federal Mortgage Bank. So I will encourage us that after this program, you can come to our stand behind and find out the products and the properties that we have. I am very sure that there are properties that you would like and that will be of benefit to you. Thank you very much for your time.
Thank you very much. Well, we are getting to the end of the ceremony. House cleaning things. There's a certificate of attendance for everybody, like I said, and the CME certificate. They're here. Okay, they're here. Oh, thank you very much, Thank you. We appreciate you so much, eh? The NMA chairman is here. Can you please be recognized? Thank you very much for coming. Thank you. God bless you. Yeah. So sorry, the program is almost over. Next year, maybe we'll come earlier. So you can talk for us. Okay, so Engineer Tunde Araoye will give us the closing prayer, and there's going to be cocktails after. There's going to be drinks if you want to stay around and drink. Don't get drunk, drink responsibly, and we can dance too. Whoever wants to dance, there's going to be a DJ, okay? So this is how we are going to do it. What's that? Well, we need to actually recognize, one of my very own sister, very own sister and brother who really helped with this. You see this edifice that you have here? Yewande Abimbola Nosoya and the husband, Femi Abimbola, provided it for us. They put up a lot of, she really helped us. Yewande, where are you, please? Yewande? This Yewande. Yewande is still to be recognized. Thank you very much. God bless you. Thank you. I really appreciate you. Thank you. Thank you. Thank you. Thank you. So anyway, today, Aroye will give us the closing prayer.
What a glorious What a glorious program we had. Can we clap our hand for Jesus? Can we do better than that? Let us pray. Our Father in heaven, we want to thank you because infectious matters are from you. Some are for good, some are not for good. Infectious diseases are your arsenals in heaven to put us to our levels as human beings. Father, we thank you for this kind of program. I was part of it in 2019. I am here today. And we thank you for everyone that has been here. Lord, this program will continue and continue and continue to the best of mankind, for the progress of Nigeria, for the progress of international community, in the name of Jesus Christ. Father, we thank you for everyone that has been participated in this thing. Lord, as they are going back home, we ask for journey mercies in diverse manners in Jesus' name. Thank you for everything. We give you all the glory. Be exalted in the midst of your people. For in Jesus Christ's name we have prayed.
Thank you very much, Pastor. Okay, Deacon. Okay, well, we thank God that we've seen the end of this ceremony. I pray that, all of us that are here this year, we are also going to be present the next event. We will not decrease in number, we're going to increase. God will promote us, God will bless us, God will give us all that we need in our lives. For every one of you that came out to support me, it's not like you don't have anything better to do, but the fact that you came out, my good Lord, wherever he is going to look at you and touch you, with his blessings. I thank you. Enjoy yourself, have drinks, have some more food, and if you can dance, network, and mix yourself. I will still be in touch with you. Thank you very much. I appreciate you all. Thank you.
Problem in all the finish. Make you try to enjoy.
Please, for those of us here, we could come out to have pictures. You want to have some pictures with Dr. Folarin right here at the front. Please come out. We could have pictures right now. Please also remember to pick your CME certificates and certificate of attendance as you go out. Thank you.
Now so then they call me for fun, so my person, don't give it person, let uncle. How will they consign me? I don't know. Problem in on the finish, you, it's your game, my life. Savannah, even the best friend, you know.
Problem in all the finish. Make you try to enjoy. Bahala in all the finish. Make you try to enjoy. Sekata uru no the finish. Make you try to enjoy. Problem in all the finish. So make you try to enjoy.
dance like Luada. Make you dance like Luada.
Low-key, all of them done they notice. I'm not joking, all my guys, them know me. Since '06, I've been writing this story. I know be OG, but if you ask them know me. I know they blow trees, only know me lonely. Music chose me, just know this and know peace. I dey low-key, but I'm never lonely. Sexy ladies, come wine for me slowly. I'm never weak, I never cease. Till eternity, I'm on fire. A legacy will not die. My family is for life. But them day, would them be? Them go crazy, them go die. Them go say, them don't know. It's in this song. Low-key, all of them done they know this. I'm not joking, all my guys, them know me. Since '06, I've been writing this story. I know be OG, but if you ask them know me.
Trabalhei, make you know they shalaye. I don't want nobody to give my matter kele. For this life I day, I want to be celebrated. Don't wanna waste my days, I want to spend them on enjoyment. It's been too long, but then it's you. Everyday party. As I did not take my do, start to move, like you smoke a lago, just they bounce with the groove. Look how they do. If you lose God, then go bounce with your boo. I can vouch for my group. I'm telling you, and do they do lifestyle of a group, make you dance to the look, then go they look, and say if it's not enough, if I do 99 goody remain one. Don't know how to show you my love without fucking up, but I can buy you a new baby, straight from me, true love.
You want no but you. Akpan-Iquot, I'm a mola, but she like what you.